Hello and welcome. My name's Alireza Sedarat, and I'm going to talk about Haiku for the Pylorus, which, for those of you who weren't sure, it's G poem. So we're going to talk about the anatomy and function of the stomach and understand how alteration of this anatomy in a specific location can provide therapeutic benefit to the illness we're talking about, gastroparesis. Talk about the indications, some of the technical aspects, and the efficacy of poem, and learn when to consider referring a patient for this. So a few things to kind of keep in mind globally. It's built on previously existing tools and techniques, namely a poem for achalasia and ESD techniques. We have a relatively limited, though a growing body of short-term literature to support its use. But the role in the care of gastroparesis has yet to be definitively established. I think it's best performed as part of a team approach because these are complicated patients. And still, as we stand here today, predicting who will really respond is challenging. So patient selection is still somewhat of an unknown. So endoscopic pyloromyotomy goes by a few names, GPOM or POP. It's an application of submucosal tunneled endoscopy adapted from the experience of the lower esophageal sphincter and achalasia and going down a step in the body to the pylorus. The goal is akin to a surgical pyloromyotomy in distinction to a pyloroplasty, which is an important distinction. The aim is to improve gastric emptying by keeping the pylorus open to alleviate symptoms of gastroparesis. So the endpoints are all symptomatic, quality of life, perhaps nutrition may be an objective one, hospitalizations, things like this. So the function of the stomach is interesting and much more complicated than meets the eye. Initially, its function is to accommodate or store food as the bolus comes in. And then it starts the process of churning and digesting with acid and pepsin, mechanically grinding the food. And as it moves from the fundus in the proximal body down the body and towards the antrum, this mechanical grinding progresses to homogenize and increase the surface area of the food bolus, and then ultimately release the food in a regulated manner into the duodenum. There's an interesting mixing titration that happens in the distal antrum and pylorus, wherein the muscular antrum and pyloric channel pushes the bolus against a almost completely closed pylorus. It's only open a couple millimeters, and so that sort of squirting or jetting of the bolus through the pylorus allows for introduction of only small particulate food into the small bowel to aid in digestion by enhancing surface area. Ultimately, large pieces that can't be ground up like that, fibrous foods, that kind of stuff, is expelled into the small bowel during phase 3 of the MMC, the migratory motor complex, when the pylorus goes from that sort of more closed state into an open state. There's also an important neurohormonal function that we're increasingly trying to understand, involved in appetite and, for example, ghrelin and similar hormones. So we'll talk about a case. This will be a case-based type discussion. This patient is middle-aged, otherwise very healthy man, kind of a bodybuilder with achalasia. Was diagnosed roughly 15, 20 years ago. He had a Heller myotomy, didn't do all that well. He had a redo that really didn't do well, and then ultimately a poem elsewhere. And after his poem sort of started to get his dysphagia a little bit under control. He was able to put on weight. But after his second Heller, prior to his poem, he had new GI symptoms that were not just esophageal. He had bloating, nausea and vomiting, postprandial discomfort. It was very much limiting his quality of life. He had food aversion. And ultimately, he was diagnosed as having a very significant delayed gastric emptying. He had a couple of Botox sessions that had variable and somewhat short-lived partial relief. But those were interesting, though, that he did have some relief to pyloric-directed therapy. So we'll keep that patient in mind until the end. So this is kind of my working definition for gastroparesis. It is a heterogeneous gastric dysmotility syndrome of varying causes, resulting in a convergent phenotype characterized by delayed gastric emptying with associated attributable disturbing symptoms. And delayed gastric emptying is ideally measured as a 4-hour study in the absence of narcotics or similar medications that can delay gastric emptying and during euglycemia. Importantly, although uncontrolled long-term diabetes will result in delayed gastric emptying, acute hyperglycemia will also result in delayed gastric emptying. So if you take any one of us that aren't diabetic and instill glucose intravenously until our glucose is above 200, our gastric emptying studies will be abnormal. So it's important that we define the patients correctly, and obviously exclusion of a mechanical obstruction. So there's a variety of mechanisms of gastroparesis that are ill-defined, and probably not all patients have all of these abnormalities. And so that's where this sort of heterogeneous population with a convergent phenotype comes in. And we're just starting to understand with various functional mappings of the stomach what gastroparesis really means. And perhaps it's more of an amalgam of multiple disorders that should be treated differently. But in general, some of the mechanisms that have been proposed and investigated are lack of accommodation to the fundus, and so patients have early satiety because the fundus is unable to appropriately do what its job is. Various hypomotility, pylorospasm, an incoordination between the antrum and the pylorus and the duodenum, a so-called dysrhythmia or a gastric arrhythmia, a neuropathic component, and a component of visceral hypersensitivity. And these mechanisms can be defects, have demonstrated defects in morphology of a variety of cells, including neurons and smooth muscle cells, and perhaps my favorite cell, the interstitial cells of Cajal. There have been demonstrated increased concentrations of inflammatory cells, but the significance of that isn't entirely clear. It's a bit of background. It's incidence and prevalence listed there for you, but importantly, increasing hospitalizations, recognition, cost, healthcare utilization over the last couple decades, which I'm sure you all appreciate. Causes are somewhat myriad. A significant proportion are idiopathic. Diabetes, we all know about. The post-viral gastroparesis syndrome is well recognized. One that we may be talking about with our patients, a post-operative vagal-mediated injury. Other neuropathic syndromes such as Parkinson's disease, myopathic syndromes such as scleroderma, and medication-related primarily opiates. The cardinal symptoms are those that one would expect: nausea, vomiting, early satiety, postprandial pain, fullness, discomfort, subjective bloating or objective visible distension. There may be associated weight loss. There may be aspiration and uncontrolled reflux as a result of poor emptying. This is the GCSI, the Gastroparesis Cardinal Symptom Index. It's a useful scoring system used in interventions of gastroparesis to gauge subjective improvement that kind of tries to quantify some of those. So it's not necessarily something that you would have to use day to day in the clinic, but it's important to at least understand and seek out those symptoms and try to gauge improvement over time with therapy. So what do we have to treat? If someone's on opiates, getting them to stop is important, though often difficult. The patients who generally have the worst outcomes are patients that are on long-term opiates, have pain-predominant complaints, and are unable to get off of opiates. Some dietary modifications that may work in mild cases: low fat, low fiber, high protein, liquid meals, small frequent meals. Prokinetics that you're familiar with, prucalopride is perhaps the most promising, newest member of that class, and a lot of people are able to get some relief compared to some of the older agents. Some patients are severe enough to need a feeding tube. Surgery is not terribly standardized for this condition. It tends to be institutional if it's offered at all, and there's very little experience with how best to approach these. They range from simply pyloromyotomy or pyloroplasty all the way up to Roux-en-Y gastric bypass procedures, gastric volume reduction procedures, gastrojejunostomy simply, things like this. And then, of course, what we're going to talk about is GPOM. So GPOM is a novel submucosal tunneled procedure similar to esophageal POEM for achalasia applied to the pylorus. And it has very similar steps: an injection, incision to enter the submucosa to allow a tunnel to get to your endpoint of the pyloric ring, perform a division of the pyloric muscle or myotomy, and then close the incision that you've made to enter the submucosa. So here's POEM for achalasia, demonstrating that tunnel, myotomy, and then closure. Here's a patient with Zenker's diverticulum, and we were doing something similar: incision to enter the submucosa, expose the cricopharyngeus here, dissect on both sides, perform a cricopharyngeal myotomy, and then close the incision. And so now we're talking about GPOM. Incise the mucosa, tunnel in the antrum, approach the pylorus, divide it, and close the entry point. So it's a relatively simple procedure, especially if one is familiar with esophageal POEM. It takes roughly half hour, 45 minutes or so. But whether it helps or not is a target in evolution. But even in the very earlier literature, it was very promising, and that's why it's kind of stuck around and warrants discussion and investigation. And in an illness that options are limited and clinical response of 70%, 80% is kind of not really heard of, these early experiences have given a lot of patients hope. So this was the first multi-center study. It's only 30 patients, but 86% did very well with admittedly short-term follow-up. This was a retrospective series looking at more quality of life and hospitalizations and things like this, and demonstrated decreased healthcare use and ER visits and improved quality of life at 6 months, with improved scores up to now 12 months for GCSI. Here's another multi-center, now international study with only 30 patients, but again, 85% significant improvement with follow-up almost up to a year. And they also documented improvement of gastric emptying scores. This is the largest single center study to date, at least published outside of abstract form. 100 patients, relatively safe, and had significant improvement of GCSI, had improvement of 4-hour gastric emptying, and improvement of severity. And interestingly, at the 3-month follow-up, a significant portion had normalization of gastric emptying, which is interesting, though it's not clear that normalization is necessary for improvement of symptoms. So when you don't have enough data, you do a meta-analysis, and this is 7 studies of up to 200 patients, and had roughly the same types of outcomes: 80-ish% improvement of symptoms, and associated with some mean reduction of gastric emptying, and a few adverse events, generally managed conservatively, and abscess needed percutaneous drainage. So this is the most recent meta-analysis, now 230 patients, and again showing favorable benefit for both symptoms and gastric emptying. Very little comparative data about GPOEM out there. This was an interesting retrospective propensity matched study of 111 patients looking at the gastric pacer versus GPOEM for all comers, and in a matched analysis there, the response rate was significantly higher for GPOEM with a lower adverse event rate. So the gastric electrical stimulator is an interesting technology that seems to have been orphaned a bit. Its role is very unclear, and you have to wonder if perhaps GPOEM may put the nail in the coffin of that intervention, yet to be determined. It's interesting that we're trying to figure out who will benefit from gastroparesis. In early experience, it was felt that the best patients were post-surgical patients where vagal injury was suspected, and that diabetic patients were not the best patients. Perhaps idiopathic were better, and there was heterogeneous outcomes in these different 20, 30 patient experiences. This is kind of interesting because it suggested that the etiology didn't matter so much. What mattered is how long they had the illness. So just to kind of throw it out there, but food for thought, and just to highlight that we don't really know exactly what we're talking about when we're trying to talk about patient selection for this disorder. So how do we figure out then who we should send to GPOM if we don't really know? Perhaps we can use response to prior pyloric-directed therapy, and people have used response to Botox and response to pyloric stenting as a means. This is certainly not standardized, and as you know, Botox is in randomized trials, 2 randomized trials, not felt to be efficacious, but perhaps that's because in those trials, they were selecting themselves for the ones that did better, were the ones that a GPOM would have worked. And so maybe it is something to think about. Is the etiology of disease a way to select patients? It's unclear. It seems that generally postoperative patients do a little bit better with pyloric-directed therapy, but it hasn't been definitively established. Duration of disease we talked about. I think one of the important ones is the type of symptoms, and primarily someone who has a pain predominant syndrome as opposed to a satiety, nausea, food aversion type syndrome is an ill-suited candidate, particularly a painful syndrome that's opiate dependent. Those are patients that are probably unlikely to benefit from most interventions. So how do we figure out, maybe with some testing? The gastric emptying study is not specific to the pylorus. Perhaps endoflip of the pylorus, which is a means of trying to measure the compliance of the pylorus. So that's been investigated, and standardization of that has yet to be developed. So here's our case. To remind you, he had achalasia, a couple of interventions, and developed gastroparesis. And this is a common situation, someone who has complicated foregut surgery developing gastroparesis. So you saw his pylorus, not particularly closed, not particularly spastic. That endoscopically doesn't mean much for response to this therapy. So we've made a submucosal injection at the antrum, a few centimeters away from the pylorus, dissecting the submucosa to enter the submucosal tunnel, very akin to esophageal palm. And you can see the musculature of the antrum at the bottom of the screen. And what's a little different with the stomach compared to the esophagus is that there are generally larger and branching vessels that look a little scarier. They tend to bleed a little bit more, these so-called penetrating vessels from the muscularis propria. So you can see, thought we had it cut into it a little bit, to get a little more. It's somewhat typical of the stomach. And so we're continuing to dissect just above the muscle layer. We're cutting through that coagulated vessel. And we continue dissection until we have this very distinct, interesting uphill tunnel where a pyloric ring is identified and then takes a sudden downhill in the submucosa fibers and vessels towards the duodenum. So now we're dividing the pyloric muscle. Perpendicular and in front of us is the duodenal bulb. And injury to that is to be avoided at all costs because it's very difficult to repair. You may be able to see in the submucosa of the duodenum in front of you there some Brunner's glands, the yellowish glandular looking things you may see on some of these views. And so we're just doing a little stepwise myotomy. We switched our knife to a insulated tip knife to avoid injuring the duodenal mucosa. We're just coming down in a stepwise way, dividing the pylorus pretty much until the serosa. See additional fibers being cut there, hooking onto them and dividing. It's a pretty thick muscle, as you can see, as you would expect, especially at the greater curve posterior side. It's not a perfectly symmetric muscle. It's a little eccentric, and it's thickest in that side. You see that We're switching our knives to do a little bit more of a sharper, finer dissection at the very bottom of the pylorus there. We've done our job of dividing it pretty completely. And you see the duodenal submucosa there, and the pylorus is divided. You don't want to come back too far into the antrum because you want to maintain as much as you can some of the forward propulsion of the antrum. So you don't want to extend too far the myotomy into the antrum, but you want to make sure you get the pylorus as complete as possible. And so now we're closing our defect with clips. I tend to suture it nowadays. It's a little easier in the stomach compared to the esophagus to use a stitch. And now we're done. And he did really well. He was admitted overnight. He had a post-operative upper GI without a leak, and he is really, really happy. In fact, I was somewhat of a skeptic about this procedure, and this patient convinced me otherwise. I mean, he had life-changing. He has essentially 0 GI complaints. He was, in fact, getting, interestingly, G junction dilation on a regular basis, something like 3, 4, 5 times a year. For recurrent dysphagia, and I suspect that that's because of uncontrolled reflux injury to his post-myotomized LES or his G junction. Since his GPOM, he's required no dilation, and so that's kind of interesting. So when do you refer a patient? Almost any time. Obviously, you want to confirm the diagnosis with the appropriate workup. You want to think of patients that don't have that sort of opiate pain predominant syndrome, and think of patients that maybe have a shorter duration of disease, have predominant nausea, vomiting, early satiety symptoms as opposed to pain. And it seems that postoperative patients are those that we tend to look for as well. Prior, for example, Nissens that have gotten gastroparesis, prior esophagectomy, et cetera. So GPOM, it's a promising tool to treat a difficult condition that previously had limited therapeutic options. It's performed with available tools and techniques adapted to this procedure. Its short-term efficacy is very encouraging and better than what we've had in the past. And it should be offered to selected cases as part of a multidisciplinary approach. But as we've said a few times, the exact role in the patient selection for wider adoption has yet to be established. Thanks very much for your attention.